along with the 2015 and 2016 PAFs. So the big goals in 2015 were essentially to continue with phase three. Through CHOP, we wanted to increase community reproductive and basic preventative health knowledge through these workshops by training two peer educators to run these workshops. And the target groups, as it says, it's men and women in the 15 to 30 age range in some of the target communities. And the goal was also to provide personal hygiene awareness to some of the children and the migrant schools in these same communities.
So for 2016, the goals were very similar to 2015 and years prior. It included preventative health, getting easier access to birth control, condoms, and then again informing communities with personal hygiene. So very similar to the years prior. They also developed more focus areas to help phase 4 with training and creating more workshops. And they kind of use that information that they got to kind of build for the future. Another goal that's different is that they were trying to train the additional 20 peer educators because there were many that were being relocated, and there were a lot of reasons for why different peer educators were moving around. And so the target group for 2016, the age group was 15 to 45 in 14 communities. And then the Burmese migrant students from 7 migrant schools. So we, for almost each workshop, there's going to be this thing called M&E data. And so there's qualitative data for this and quantitative. So the qualitative includes information on communities and thoughts on specific topics for improvement on future phases, like previously with the focus areas. Okay, I see a question in the chat. What does M&E stand for? What does M&E stand for? I'm going blank. Does anyone want to help me answer that? Monitoring and evaluation. Thank you. And so the qualitative, so that helps for future workshops being built, and we use the opinions from others and try to build better things in the future. And so the quantitative data included specific records about for example, the number of participants that were in a workshop, and number of women and men. Some even have the cost and when it happened and stuff like that. So that can also be used for the future phases as well.
Yeah, so the mobile medical team, first things first, is a discontinued service, but originally it was a health outreach team designed to enter rural migrant communities to provide basic healthcare services and reproductive education. So talking about the problem that really initiated the mobile medical team was many of the migrant workers lived in communities located near fields that they worked in for their Thai employers. And these employers and landlords, they rarely provided proper sanitation or running water. So community members often resorted to rain, ponds, or stream water to wash, cook with, and drink. And this problem was further exacerbated by the fact that lots of this water was contaminated by runoff of the chemicals used in the fields that the migrants worked in, along with the fact that there was widespread drug and alcohol abuse in these communities. So some of the objectives of the mobile medical team was to increase access to basic health services by targeting 2 to 3 communities weekly and rotating through about 44 communities annually. That way, each community would receive a visit approximately every 3 months, and they were trying to see 70 patients a week. Additionally, they wanted to increase family planning supplies and provide logistical and financial support for any referrals that the physician would have to make beyond the basic examinations they do at these appointments. And these logistical and financial support would be provided through some social workers that also worked on the mobile medical team. In terms of the history of the team, it initially operated, I guess, independently from 2002 to 2003, and it was revamped in 2010. And from 2010 to 2012 is kind of the heyday of the mobile medical team. Treatment was provided to 6,831 patients, and the goal of 70 patients a week was reached. However, by 2014, mobile medical team had to be scaled back and visit their rural communities only on Sundays. And by 2017, the team was scaled back even further to where only 8 trips were made to 8 rural communities over the year, and only a total of 285 patients were seen. So there were inadequate funds to pay a doctor full-time salary, so the program was then discontinued after this year. So our big idea slide. So why are M&Es essential for the success of CHOP and SAW as a whole? If you're having trouble thinking of something, you could think of ways that we can look back and look at the M&Es and what kind of discussions they would become useful in. That's kind of how they're okay. We have really helps reallocating resources for upcoming years. I think that's a good one. That really hits it on the head. Yeah. And then Matthew added also reassessing what topics should be covered in a CHOP workshop. So
Okay. Well, thanks for